Thank you so much for being here at this webinar today. I feel that we've met before. I have an announcement. My friend and colleague Stephanie Acquilano had a last moment conflict and she's not able to join today. I will present her part. I'm sure I'm going to do a little bit less of a good job than she would have, but please bear with me. And I think I'm confident I can answer though most questions that may arise from her part. So here we go. So what we're going to talk about today is an overview of co-occurring disorders, and that is the co-occurring mental illness and substance use disorders. A little bit of overview of the treatment. And I think many of you are quite familiar with the condition of co-occurring disorders. And many of you are familiar with at least the various aspects of treatment. I'm trying to just put them all together and present you also some results of a small study that was done of a comprehensive program treating people with co-occurring disorders, and hopefully just to show you that a comprehensive treatment seems to be working in a real setting. Sorry for the delay here. I have to get used to press the right arrow. So co-occurring disorders, as you know, means the coexistence of mental health and the substance use disorder. And this is quite common. A lot of people with primary mental illness also have a substance use disorder, and the other way around, people who have a primary substance use disorder develop or have also a mental illness. And in fact, in many cases, we can say what's primary and what's secondary. The fact is that they both coexist. And it seems that reasons for this coexistence are structural, among other things. It seems that it's more and more evidence that there are shared genetics, that some of the genes that are seem to play a role in a certain mental health condition also play a role in developing an addiction. Addiction, as you may know, has a large genetic load, so 40 to 60% of the responsibility for developing an addiction is genetic. And those same genes also can be responsible of developing a mental illness. There are shared brain circuits. There's a lot of talk, of course, about dopamine circuits in the brain. And I think that researchers who really look at circuits are saying that those circuits are very complex, and it can be.
Well, I'm running two different programs right now.
Excuse me. I think I'm hearing someone. Can you make sure that you're muted?
Yeah. Well, this is the thing that we have to listen to.
I'm sorry, what?
I'm muted. They're muted.
Muted, yeah. Shared brain circuits. So I was saying that the circuits in the brain are very complex, but there seem to be some shared circuits between this addiction, maybe dopamine involvement and dopamine involvement in serious mental illness, but it may be more complex than just the dopamine. And the same vulnerable timing, and that is adolescence, which is a prime time of vulnerability of the brain, of the developing brain, and serious mental illness such as schizophrenia, a number of other mental health conditions, and substance use disorders seem to predominantly develop then and have maybe a bigger impact subsequently. So co-occurring disorders are common. in the National Survey on Drug Use and Health, it appears that about 8.2 million American adults have a mental illness as well as a substance use disorder, or had within the last year. We also know that 50% or more of people with serious mental illness have a substance use disorder. And of course, there are many examples throughout contemporary life as well as history, from Vincent van Gogh to Ernest Hemingway to Britney Spears, who are known, and many, many others who are known to have had both mental illness and the substance use disorder. What is the impact of co-occurring disorders? The impact, it appears that people who have co-occurring disorders do have a lower quality of life. It appears that co-occurring disorders can have an impact on family and family relationships and family life, on school, on social aspects of the individual. Are associated with incarceration and homelessness. People may be or are at increased risk for undergoing some significant trauma, for being the victims of trauma. And of course, there are higher rates of suicide, especially when depression or anxiety are associated with a substance use disorder. The rates of suicide are very high. More impact on the general health. We know that people who have co-occurring disorders have an increased utilization of emergency room services. When people with mental health condition also have a substance use disorder, they have repeat admissions to inpatient psychiatric hospitals. They have, we know now, high rates of medical problems, to the point of really asking, are dual disorders triple disorders? A lot of people have comorbid medical problems, and mortality is higher. For example, this is one study that I want to put here because it was stunning. They calculated that the disease burden, and disease burden means social and financial, really disease burden on the society. Disease burden of mental illness and addiction in Ontario, for example, that's where they had the study done, is 1.5 times higher than all cancers in this area put together. So very high impact. And of course, what's not here on the list is really the stigma, because the increased utilization of emergency room services, they may get called difficult patients, right, or frequent flyers, and the people are sicker, but the paradox is that in those situations, they may get less care. It's just another slide that just to reflect a little more on the medical complications of co-occurring substance use, specifically with the rates of HIV, hepatitis B and C, because we know that people with substance use disorders and with mental illness have 2 to 3 times higher risk of having one of those blood-borne diseases than the general population. And then mortality. What's mortality due to? Well, mortality is due, as expected, to sudden, unexpected death, such as suicide, overdose, and accidents. But that's actually not the majority of early mortality in people with co-occurring disorders. The majority of mortality is due to the same causes of death as the general population, and that is heart disease, stroke, cancer, pulmonary disease, and diabetes. However, people with co-occurring disorders who develop these conditions seem to have earlier adverse health consequences, more severe illness, and again, it seems that they do get less medical care. The less medical care is not probably the main reason for the high mortality, but it's just one of the factors. There are many factors that go in there. One of the problems is just the fact that they have more frequently those conditions. They develop those conditions more frequently. Again, they're more severe. Maybe, they take less care of themselves, but also one of the factors, they get less medical care. You may have heard me say this before. The life expectancy in the general population in US is 70, 80 years old, while the average life expectancy for people with major mental illness is much lower. It can be from 49 to 60 years of age, which means that some studies that way are very hard to calculate. So different studies have led to a little bit of different results, but the issue is that Americans with major mental illness and substance use disorder die anywhere from 15 to 30 years earlier than the general population. And this drop in life expectancy surpasses the health disparities reported for most racial or ethnic groups. Yet, this is a quote from Tom Insel when he was leading the NIMH, the National Institute of Mental Health. Yet this population is rarely identified as an underserved or at-risk group in the surveys of the social determinants of health. So people with co-occurring disorders are at high-risk group, and they do need a little bit of special care. They need more care, and they need a little bit of special care, and they're not, for the most part, they're not getting it. So co-occurring disorders, in conclusion, are common. They are recurrent, right? They're chronic and recurrent, and they can be serious. They have a lot of consequences. But I want to emphasize now also that co-occurring disorders are treatable, and many people do recover. What does recovery mean? Recovery means, of course, different things to different people. But for most people, it has some measure of living independently, having some ability to control one's own symptoms, actively manage the substance abuse. So see that I'm not saying necessarily it's abstinence or complete sobriety or no symptoms, but the ability to control symptoms and to manage the substance use disorder. So the sense of being in control of that is very important for every one individual, and this part of the recovery. Very important part of the recovery is working competitively, being able to socialize and having friends and family relationships that are meaningful, and just being able to feel life satisfaction. And all that, again, is possible, but it may look differently for different people. Treatments. So we have known now for about 3 decades that treatments for co-occurring disorders need to be integrated. The history before that is that co-occurring disorders were for the longest time treated as subsequent treatments, so or parallel treatments, and we know now that those are ineffective. Unfortunately, they do still happen a lot. It seems that effective integrated treatment is difficult, is expensive, and maybe there's not enough knowledge about how to do it, and maybe there are some thoughts that subsequent treatment is good enough, and it is probably more than nothing, but it's not effective. In fact, many people with co-occurring disorders have this history where for many years they were going from one provider to another, and for example, the mental health care provider would refrained really from treating their mental health condition effectively because they were actively using substances. And then if they would try to address the substance use disorder with a different provider, they would not be able to get treatment, full treatment either, because they were symptomatic from their mental illness. They were too depressed or too psychotic. So people have these histories of really fragmented and ineffective treatment. And therefore, effective treatment has to be concomitant and integrated. So in the last 3 decades, we've had a lot of research showing that, yes, that is true. But this is still the problem, what Dr. Drake calls the 95% problem, which is that people with co-occurring disorders, in fact, the majority of them get no care. 25% get inadequate care, 10% get minimally adequate care, and only 5% get the evidence-based care. And this is a huge implementation gap. We know that there've been many studies showing that trying to underline how to provide integrated treatment. And we know that the mental health and the addiction treatment, so it has to be combined and delivered by one team, one provider or one team. And then also that's not enough. It has to be tailored. There are some things that work particularly well for people with co-occurring disorders that have to be part of this treatment. They may not be part of either the two treatments. So it's more than just the sum of two treatments. It is the sum of two treatments in one provider or team, but there are also some other specific elements that seem to be working. And there is data, as I was saying, the percent of participants in stable remission for integrated treatment, which is really high fidelity assertive community treatment programs. So the percent of participants in remission, it's much higher in those centers with those teams that can really implement these evidence-based practices that we're going to talk about a little more. So again, so what are the principles of effective integrated treatment? So first of all, as I've said, integration, mental health and substance use treatment delivered by one team. Assertive treatment, an assertive community treatment team. And stage-wise treatments, and I'm referring to the stages of change here. So treatments can be delivered according to where people are at, and that refers to either their substance use disorder or their mental health. And we're going to have the opportunity for a little bit later to review the stages of change. But if people are not, let's say that if people are not ready to address their mental illness, that doesn't mean that there shouldn't be any treatment. There should be treatment, but according to that stage of change they're in, which is pre-contemplation, and then the intervention has to be tailored that way with a lot of motivational interviewing and increasing ambivalence and just creating therapeutic engagement, for example. Another important element is family support. As I mentioned before, many times when people have significant illness, the relationships with the family are strained, maybe even fractured. But family is very, very important in treatment, and family is an important participant to the individual's treatment. And restoring those family relationships ends up being a very strong motivator for people to achieve and maintain recovery, whatever recovery means for them. Not to mention that family can support that recovery in many ways. And last but not least, employment and education. That is an evidence-based practice and the principle of effective integrated treatment. People people, when they get a competitive job, when they get employment, it is, as many of you are involved in this process, and I'm sure you're seeing that people just can get much better. Like literally their symptoms of psychosis can get much better. And again, getting competitive employment creates hope and is a strong motivator for recovery. So this is a slide I like a lot, and because I like it, I'm going to show it to you several times. Sorry about that, but it's a slide that is trying to look again at what can be different elements of an integrated team. And what are a number of evidence-based practices that that could be used in the treatment of co-occurring disorders. So let's say, you know, starting with the A for admission at the top. So this circle is obviously an integrated team, and it has teamlets or sub-teams in it. And it doesn't mean that those sub-teams are different people. They can be, the different people can be part of one person can be part of different teamlets and have many roles. And that's actually part of the strength of an integrated team. But there can be a process of admitting a person to an integrated co-occurring disorder program. And the admissions, it's very important to do the work of getting comprehensive information beforehand and making sure that there's a warm handoff from wherever this patient is coming from another team, from another provider, from a hospital, from the family, from home. So getting, even before, prior to the admission, being able to get enough information about them that is clinically relevant, and having that warm handoff when there is person-to-person transmission of information, some contact between two teams when the care is being transmitted, it ends up being very important. And also make sure that the team, the receiving team, is really has an understanding of this person already at day one, you know, so they can make treatment plans, and they can prevent crisis more effectively, and make treatment plans sooner. An integrated treatment like that, integrated team might have a residential treatment place, which is obviously it's not a hospital, but is a place where people can be admitted to if they are in between, if they experience an exacerbation. Outpatient treatment is not enough, but you know, they don't really go to the hospital. They go to this intermediate place, a residential place, where they can be for a period of time, and that residential treatment is focused on co-occurring disorders, so treats both aspects of the illness. The very important element is then the assertive community treatment. That the team, and we're going to talk a little bit more about it, but that is the basis really of all integrated treatments. One team, long-term treatment, assertive, and you know, trying to help people integrate in the community. Peer mentoring is very important, and it gets actually woven into this into the assertive community treatment. But peer mentoring has been shown over and over again to be helpful in managing substance use disorders, chronic mental illness, and really chronic medical illness. So peer support, whenever possible, should be, I mean, if integrated into a treatment, is effective. The medical part needs to be part of this comprehensive treatment, because as we've seen, people with co-occurring disorders also have high rates of medical illness. And the medical illness oftentimes doesn't get treated correctly. One of the reasons may be that people, they don't even have like a primary care physician. They don't go. Maybe they don't have insurance, or but also when they go, there are some studies that show that even when people do go to the hospital, or when they do have a primary care physician, there's a significant percentage of people with co-occurring disorders who do not get appropriate treatment. Like simply, in a primary care practice, when there are people, general population, and then people with co-occurring disorders, and it seems that on average, people with co-occurring disorders just get like less aspirin prescribed, less diabetes medication, less high cholesterol medication, even when they have the same numbers as other people without co-occurring disorders. And in the hospital, there was a very sobering study. In the hospital, people were being admitted for heart attacks. And at the time when the stents were the intervention, recommended with heart attacks, just seemed that people with co-occurring disorders were just getting less stents. Now it's in retrospective, now maybe that's not such a big problem, because it turns out the stents are not necessarily the right treatment for heart attacks for many people. But that study was probably reflective of the stigma that people with co-occurring disorders encounter. So in addition to medical, and we'll talk a few more words about how can medical intervention be integrated, there's another aspect that's kind of related, but it's also separate, which is wellness. And it's all, the focus on diet, exercise, smoking cessation, sleep, all the healthy lifestyle that makes a lot of difference in everybody's health. The next sub-team is the team that would deal with the family. And families, this stigma of mental illness and substance use disorders does extend to the families in all kind of ways. When families have members of their family who are sick with co-occurring disorders, they get less support in the community. Some families were expressing that, like if their loved one would have had diabetes, they would have had a lot more support in the community. And if they had had a heart attack, families get like meals from neighbors. But when people have co-occurring disorders and they have exacerbation of mental illness or the addiction, there's just shame and guilt, and a lack of community support, and a lack of from the family too. They try to actually not say anything about their loved ones. So that's one problem, that magnifies a family's distress. Another one also comes from stigma. 100 years ago, somebody in psychiatry thought that mothers or families may be responsible for some of the mental illnesses. And unfortunately, in some places that is still sticking, that is still the case. And families get rejected from care, when in fact they should be involved in care for everybody's benefit. Last, and then again, there will be an opportunity to talk a few more words about family, but the last part is supported employment and getting people competitive jobs, and that's a very important part of treatment. So going back, I'm just going to talk a little bit more about the assertive community treatment, medical, family, and support employment, the essential parts of an integrated treatment. So assertive community treatment, many of you may be familiar with, and maybe practicing or be part of a team practicing assertive community treatment. And so just as a reminder then, I don't want to insist too much on it, but of course, ACT means continuous, comprehensive, and flexible care. With a full range of medical, psychosocial, and rehabilitation services. It's a community-based team, 24 hours a day, 7 days a week. So the individual receives care from the same team, not from the same person, obviously, but from the same team, as opposed to like going to the hospital and then being sent to a completely different set of providers. This is a team that manages exacerbations in the community. It is long term. People are not really supposed to be discharged from ACT. I don't know if ever, but not for a long time. Treatment is not prescriptive. I mean, there are a lot of principles of care and there are evidence-based practices, but treatment is individualized and adapted to the needs. And then the goal in the end, of course, of ACT is symptom reduction and prevention of exacerbations of reoccurrences of substance use or mental health symptoms. The ACT team members can be care managers, psychiatrists, nurses, vocational specialists, mentors, peers. And some of the ACT specific interventions are, this is actually not comprehensive, but these are maybe some of the specific interventions, because with every one individual, depending on where they're at, they may need support with one thing versus another, right? So the treatment plan can include some things for everybody and some things just for some people, depending on what they need. So it's activities of daily living, really, help to live independently. Housing support, of course, outreach is very important. And in that case, people do not get lost to follow up, which so often happens in outpatient practices, people that don't show up and then there's no system in place to basically outreach them, to look for them. They just didn't show up, they dropped out. Outreach is very important. Medication education and supervised administration, and then teaching people strategies to improve medication adherence. Nutritional education, smoking cessation, healthcare collaboration, individual and group therapy, nursing services, family support, vocational, mentoring, wellness coaching, emergency services, respite, and some programs have alumni, which is people who completed the program and then they maintain links and they are in a peer mentoring position. So again, this slide, my favorite slide, just to remind you that next we're talking about the integrated medical treatment and what that means. So first of all, one of the things is screening and monitoring for medical complication of psychiatric and substance use disorder treatment. And we know that psychiatric treatment and substance disorder treatment can be associated with weight gain, with metabolic complications. So having a place where individuals can, like in their community or in mental health center base, get their weight measured, their vital sign, blood pressure, heart rate checked, be sent for blood work monitoring, and every now and then, if appropriate, an EKG. All this is part of integrated medical care and goes a long way in helping detect problems that easily go undetected otherwise. Of course, establishing and encouraging follow-up care with a primary care provider, very important, and that can be part of what an assertive community treatment team does. So obviously it doesn't provide primary care, but helps people find a primary care provider and helps them follow up. Advocacy is very important because, as I mentioned, you know, there's so much stigma, and it occurs, it is visible in many ways. It affects people in so many ways, if people can have somebody on their assertive community team to just help them, to just be their advocates and say, you know, this person is really sick. They're not like that. They don't look like that usually. They're really sick, and I'm here to tell you that. Or just insist, just help clarify or articulate the symptoms and so forth. There's a lot of ways to advocate, and that's very important. Then help with just navigating the medical system. The medical system, as you might know, is just very complicated, and if you need care, it's hard to get. Phone calls, appointments, follow up in all kind of ways, keeping track of everything. People, especially if they're in the midst of also having mental health illness and symptoms or substance use symptoms, they could benefit from help navigating the medical system. Then there could be a whole work of preparing the medical appointments. So that means just checking with the individual before the appointment, helping them write down a few things that they want to check. They want to have checked with the provider. It's so easy to forget once you are at the appointment what you wanted to talk about. So writing a list of 3 things or of concerns, and bringing them up front at the beginning of the appointment actually helps the appointment go smoother. Another way that an ACT team member could help with is just make sure that relevant medical information is provided to the medical provider. So bringing in a list of diagnoses, a list of medications, an accurate list of medications, and also try to help write down instructions for follow-up care and communicate the plan back to the rest of the team or to the psychiatric care providers. Some other, assertive community teams also do some work of screening, additional screening. That's also a preparation for the appointment. So like vital signs or even preparing the psychiatric appointment with screening with some known scales and so forth. Some of you may be familiar with that. And then, of course, after the appointment, support the individual in implementing the plan and following up. And of course, then is the healthy living, all the little information even, doesn't have to be highly specialized, but there are some things that are obvious that people can use some advice and some help with their grocery list maybe, or what are some obvious things that need to be avoided or cut down on or replaced with. Going through some steps of developing an exercise plan, some very simple steps, some stress management, smoking cessation, or some principles of healthy sleep hygiene. Here's the slide again. So we'll talk just a little bit next about family involvement. As I mentioned, family members have their own recovery journey as well, because families, they have such a complex role. They are the support system. They do serve as experts on the individual in certain ways. Okay, maybe they don't know other things, but they know that person really well, and they can help with relaying information to the providers. They are, of course, the primary source of many health-related beliefs and behaviors. They do experience stress as a whole unit. They do need knowledge about what's going on with their loved one. They may have unintentional counterproductive interactions, lots of them sometimes. Maybe those were built in years and years. But there's always, that most times by far, they're not ill-intended. And I think that that's very important. They do experience caregiver burden. They do help with reducing housing instability and homelessness. They do reduce the risk of relapse and really can be anchors. So what kind of intervention can an assertive community treatment do that's supporting the family? So first of all, just starting with the idea that as much as possible, if, trying to get an alliance with the family is important, except for when there's clear abuse. In all the other instances, even if the dynamic has not been good, an alliance may be helpful, of course, if the individual agrees. But trying to do, there are evidence-based curricula about how to support families, how to educate and support families. So there are manuals of family education and support that do assume a collaborative relationship. They do provide psychoeducation about specific occurring disorders. They do provide social support and empathy with the goal of reducing the stress and the tension in the family and increasing the healthy family connection. Improving functioning in all family members, providing hope and encouragement, and focusing on the future. This is the last time probably you're seeing this slide, just to remind you that the last part of it is about supported employment and importance of employment. I think most of you are familiar with it. We know that substance abuse, so using substances, is not correlated with employment. Plenty of people are employed and use substances and shouldn't be a barrier towards employment. So we know that supported employment is effective with people who have dual disorders. The nature of recovery is such that has to be comprehensive and has to go to people to their own goals. And competitive employment is usually a step up from Social Security disability in terms of income and and it's a step up from poverty. And I'm going to show you now. I know that maybe we don't have a lot of time now. This is Stephanie's part, data collection for outcomes of treatment. So what I presented to you, the slide I presented to you many times, there is a treatment program that has tried to introduce all these elements, and then there's been a partnership of researchers from Dartmouth and West that have looked then into this program to try to see whether it works and can we really get data about the outcomes. And that's when I want to tell you a little bit about. So these researchers collected data, that they went back into the charts and collected data about demographics, who the people who receive treatments were, their treatment history, their diagnosis, elements about their mental health and substance use, and then data about their housing, education, employment, family, and hospitalizations, both like prior to their treatment, their starting treatment, and then several years after being in treatment or ending the treatment. And they called up people and interviewed them and their families when possible. They came up with some transcripts, and then researchers went through the transcripts and tried to extract data about these elements that we just discussed and try then to analyze them to decide if people are in recovery and what kind of recovery. So recovery, it's a complex process. They identified recovery as meaning recovery in 5 or so domains. So recovery meant that people have some kind of housing stability, some kind of employment or education stability, some kind of positive relationships with their family or social relationship, some kind of control of their substance use, and some degree of control over their mental health. And in each of these 5 domains, they rated essentially 1 through 5 on how much control people have over that particular domain. And they decided, so 1 to 5, and then people who are a 4 or 5 in each domain, they were in recovery on that domain. So, so this is the part that Stephanie, I think, would be much better. But this is sometimes researchers go through really complicated analysis in order to attach measurable meaning to usual words. So what does it mean that people are in recovery? So for example, here they put the 1 through 5 are really the stages of change. And I'm not going to bore you too much with that, but in your left column, the substance use stages of change are the classical ones that have been described in the literature. So pre-contemplations means actively using. Contemplation is, well, using, but considering pro and cons of use and considering change. Preparation is taking steps to reduce substance use. Action is actively working on abstinence, and maintenance is abstinence. And similarly, they try to use a similar scale to when they were evaluating, for example, family relationships. So they call pre-contemplation being a description of a relationship where people are overwhelmed by conflict and essentially they have no contact. And a second stage of contemplation was they had difficult relationship, but they're actively working on that, on the relationship. The preparation would be at least one positive interaction per week. The action stage is positive interaction most of the time, and maintenance is satisfying age-appropriate interactions nearly always. So again, you see here that if people from all this data and the interviews, and two separate researchers looked at the interviews and then tried to decide in which stage of change people are on these separate domains from what they were saying, and they had those two separate researchers had to be in agreement. And you can see that, for example, in family relationships, if people were in a stage of 4 or 5, then they were considered in recovery. Anyway, in these programs, there were 82 men. They were relatively young. I think the average age was 28. They were single by the majority were single and Caucasian. And they had gone to high school and some college. They were unemployed. Their main diagnosis was schizophrenia or bipolar or major depression. As you know, I mean, most people had more than one diagnosis, but those were the main ones, the primary diagnosis. And then most of them had polysubstance use. Some had cannabis, some had alcohol use disorder. And most of them had had multiple treatment attempts before getting into this comprehensive integrated treatment program. So these are the 5 domains of recovery: housing, education or employment, family, mental health, and substance use disorders. So people who had been in this comprehensive treatment programs for 12 months or more had much higher rates of recovery than people who had been in the program for less than 12 months, who had been discharged before 12 months for various reasons. So that was important to know. And again, this program was a combination of residential followed by ACT. And it didn't matter, it seems like, necessarily how much they were in residential. They probably, when they were better enough to be in ACT, they were in ACT, and that didn't matter. It mattered how long they were in treatment overall. And people who had 12 months of treatment, they were doing a lot better with rates of 70 to 80% recovery, which are really rare in the co-occurring disorder treatment. Number of domains of recovery. People were in recovery on more domains if they stayed longer in treatment. So they were getting things under control sequentially. That was important. They looked at hospitalization, and people who stayed in treatment for 12 months or more had much lower rate of additional hospitalizations. Before the treatment, most people were on an average of 4 admissions to the hospital, and after being in ACT, for 12 months or so, they barely had maybe one hospitalization, if any at all. One was the average for 82 people. The other thing was that family involvement was significantly correlated with recovery in most of the domains, except for employment, unclear why, but housing, relationship, mental health symptom control, and substance use control were much more likely to be in recovery if family was highly involved. So this is, what I want to present to you today. We'll have just a few minutes for questions. Just that, what are the principle of really integrated treatment? What are elements that seem to be working? And then even some data that a program like that has all these elements and that treatment is for at least 12 months seem to produce high rates of recovery. So again, the treatment that I was talking about was the original ACT model, which was enhanced with other evidence-based practices such as family education, supportive employment, and collaborative care around the medical and psychiatric issue. And the conclusion that there are high rates of recovery when appropriate treatment is provided, so people with co-occurring disorders can actually lead satisfying, harmonic, and productive lives. And that treatment and support need to be long-term, flexible, and multidimensional. And this was my last slide, and I would like to open it up for questions. Thank you very much for listening.
Thank you, Delia. If anyone has any questions or comments, please type it in the chat box and address it to the entire audience. If you wish to speak during the webinar, just click on the little raised hand icon. I can unmute your microphone, which will allow you to speak. So there are a couple ways that you can actually communicate with the presenter. We're going to give everyone a couple minutes if they're typing questions in.
Sure.
It looks like Don has a question.
Okay, go ahead.
Don, your mic is unmuted.
Okay, thank you. I just wanted to say I'm from the Healthcare Authority, and I work with agencies who provide foundational community support, supported employment, and utilize individual placement and support. The program you mentioned from originally developed by Dartmouth, now overseen by Westat, and it is incredibly effective and something that I'm glad to hear you mention. I also just wanted to say thank you for your presentation, very interesting.
Oh, thank you very much. I am always thanks very much for that comment. I am very much surprised, when I myself, I'm a psychiatrist and follow people with co-occurring disorders. And I've had people who had been chronically symptomatic for years, and maybe didn't want to get a job or whatnot, but then they did get a job. And literally, it's not that overall they're doing better. It's very literally their psychosis symptoms are much diminished. It's amazing, I think. And not to mention the fact they're just much more hopeful and engaged and feel differently about themselves. It's, yes.
Absolutely.
Thank
And
you.
when
I
we think
appreciate
about the
it.
benefits that employment provides to each of us in regards to connection, and money isn't a bad thing, and various other
Yeah,
things, does the same thing for people that we serve.
exactly. Thank you.
Thank you.
Any other questions or comments? Doesn't look like any questions are coming up, Delia.
Okay, well, thank you everybody very much for listening. And that we have consultation sometimes if there are additional questions later on. But thanks again, and thank you, Carl, for supporting it.
My pleasure.
Bye bye, everybody. Have a nice rest of the day.
Thank you, everyone. This concludes the webinar today. We'll see you again on the next webinar, and have a wonderful day.